Hi, I'm Dr. Sheldon Cheskes, Medical Director, Sunnybrook Center for Prehospital Medicine. As Medical Director for Halton and Peel Regions, I review all cardiac arrest files that come my way. And occasionally you get a case that is just so special it's something that you use for teaching in the future. The case I'm going to present today, I title Lucky 13, a case of high-quality CPR, and in it, I hope to be able to show you one of those particular cases. The objective really of our talk today is to demonstrate the concept of high-quality CPR, demonstrate the importance of short peri-shock pauses, compressions during charging, and high compression fraction during prolonged cardiac arrest. I want to also be able to show the demonstration of an integrated system of care for patients who sustain cardiac arrest, and as Yogi Berra often said, remember the phrase, it's never over till it's over, and I think that's really going to be highlighted in this case. Just as a review in something that we published a little while ago in terms of shock pauses, here's a slide that demonstrates the pre-shock pause being the time between the last compression and shock delivery, post-shock pause being the time between shock delivery and resumption of chest compressions, and peri-shock pause being the combination of the two. The key results of our previously published paper showed significant relationship between both pre-shock pause and peri-shock pause compared to those patients who had longer shock pauses. Remember, we did not find any significant findings related to post-shock pause in our previous study. In our case today, what we saw was a 65-year-old male who was at home watching TV. He said to his wife, "I think I'm having a heart attack," and immediately slumped on the couch. The interesting thing about that is whenever we teach medical students and residents, one of our favorite things that we always worry about is when a patient says they're going to die, they're actually usually right. So we got very nervous when that happened in this particular case. The wife was great. She called 911 right away. EMS called, received at 22:19, arrived patient at 22:23. So EMS was on scene within 4 minutes of the patient sustaining cardiac arrest. The patient went VSA with agonal respirations, and then ALS care began. The patient had no previous health problems, on no medications, nor allergies. The patient was not a smoker, not a drinker, and essentially had no risk factors for coronary artery disease. On the patient's presentation, the patient was presenting, as you see, in ventricular fibrillation. On all these slides, you'll see a top layer in terms of ECG printout, which looks at an unfiltered waveform. Underneath it, what you'll see is a filtered waveform, which gives you a better idea of what the underlying cardiac rhythm is while CPR is ongoing. So in this case, the patient presented in ventricular fibrillation. What you'll see here is a shock 1 being delivered during this particular case, and what I want you to draw your attention to is a very short pre-shock pause of only 2 seconds. After shock delivery, a post-shock pause of only 1.5 seconds. So this is incredible to see this on one shock. What we'll see, though, is a repeat of this particular performance. Here, what you'll see is a video of shock 2, and what you'll be able to see in a shortened form is a concept of compressions during charging. When you look at the CPR waveform at the bottom of the slide, a straight line means no CPR is ongoing. When you see the waveform that looks like a sinusoidal waveform in the bottom, that means CPR is in fact ongoing. So if we look at this particular video, what you're going to see is the last component of CPR, an analysis of a shockable rhythm, then a shock delivered. What you'll see then is resumption of CPR within a short period of time after the shock was delivered. So that video also illustrates what we saw in the shock 1 that was performed as well. Here we move to shock 3 of this patient, and again, replicated was a short pre-shock pause of 1 second, again a short post-shock pause of 1.5 seconds, and you'll see as CPR starts after shock delivery, you'll begin to see some QRS complexes developing. Unfortunately, these weren't associated with any blood pressure, and hence CPR may continue to occur. Shock 4 is even shorter from the pre-shock pause phase. You'll see the waveform at the bottom of the screen showing a compression occurring almost instantaneously with shock delivery. A post-shock pause, again, of a very short time frame, only 2.5 seconds. So you've been able to see 4 of the shocks that were delivered to this particular gentleman. So basically, after 6 shocks were delivered, you see the following waveform. You'll see at the bottom the last compression of the case, and finally a perfusing rhythm occurs after shock number 6. So this is the rhythm now 2 minutes after CPR with respect to shock 6. The summary of the patient's care provided was an arrival of patient at 22:23, a return of circulation at about 22:36. The vital signs are as we see above, with 6 shocks provided in the case. The reason we call this case Lucky 13 is 13 minutes of ongoing CPR occurred during the case. Intubation was delayed by about 12 minutes in this case, in keeping with the ROC trial that we're currently undergoing. Epinephrine, amiodarone, and dopamine were provided, occurring to ACLS standards. When you look at this slide, what you'll be able to see are the CPR quality measures aside from the shock pauses that we've demonstrated. You'll notice that the CPR fractions are all very high, showing a very high hands-on time performing CPR. The compression rates are all in the range of 102 to 112. You'll see the mean compression depths are all significantly deep, all over 5 centimeters. So this was a case that did not just have excellent quality shock pause durations, but excellent all-around quality of CPR. The summary of the critical CPR measures show a mean pre-shock pause of 2 seconds, a mean post-shock pause of 2 seconds. To put that into context, the median shock pause in the ROC Consortium for pre-shock pause is currently approximately 15 seconds. To see shock pauses in a case of the length of only 2 seconds is extremely impressive. The mean CPR fraction in this case is 0.83, compression depth of well over 5 centimeters. Compression rate between that 80 to 120 range, or at 106, the length of duration, 13 minutes 45 seconds. Here's a slide that's going to show you in a video format the last 2 minutes of CPR, as well as a component known as compressions during charging. Compressions during charging is the technique we use in Peel and Halton regions to shorten the pre-shock pause and increase the likelihood of a successful shock terminating ventricular fibrillation. So if you watch this video here, what you'll begin to see is the last 2 minutes of CPR. So compressions are ongoing. You then get a 2-second, this one's a bit longer, ventilation pause, followed by a resumption of compressions. At the end of the 2-minute cycle, the paramedic confirms VF. You'll see at the top it says defib charging, but they begin their compressions during the charging phase. Short shock pause, shock delivery after only 1 second of pre-shock pause. So that's a beautiful example of how compressions during charging can significantly decrease your pre-shock pause. In our system of care in Peel and Halton regions, when a patient has a return to circulation, a post-circulation or post-ROSC ECG is performed. In this case, an ECG was performed which confirmed an acute inferior wall myocardial infarction. All patients who have a return to circulation in Peel region after cardiac arrest with a STEMI-positive ECG are taken to the local cath lab, and that's what happened in this particular case. The patient arrived at the cath lab door at 23:13, 50 minutes after the time of their cardiac arrest. He was on the cath lab table a half hour after arrival to the department with a balloon up time 13 minutes later. This shows you a picture of the patient's pre-PCI angiogram, which shows clearly a culprit lesion in the right coronary artery. What you'll see here is a post-PCI angiogram showing significant improvement in circulation in the culprit vessel. Post-PCI care, the patient received therapeutic hypothermia for 15 hours, 15 minutes. Temperature drop was as per protocol from 36.9 to 31.5 after 3 hours and 15 minutes. The patient was clearly quite ill, requiring significant inotropic support and an intra-aortic balloon pump. The patient was discharged to his regional hospital on day 5 and discharged home 10 days after his cardiac arrest impressively with a CPC score of 1. In fact, the patient had very little recollection of the events of the previous 10 days. It was clearly a remarkable story of not only bystander CPR by the wife and early activation of 911, but superb care by all of those involved in this particular case. The conclusion from this case is good quality CPR saves lives, but clearly high quality CPR with short shock pauses and excellent deep compressions can save lives that we previously thought were not able to be saved. Perhaps the greatest compliment that the paramedics could receive was that from the interventionalist at the end of the case, who basically said, without the excellent care of the paramedics, this gentleman would have never survived. We really thank you for your time and hope that you're able to take away from the slides and this show the importance of good quality compressions, short shock pauses, and improved quality of care for these particular patients. I thank you.